Hello, good afternoon to everybody. It's a pleasure for me to welcome you here to our 9th Hearing Roundtable. Hearing is a very special group, and this time I welcome you from Tel Aviv in Israel. We have a wonderful live surgical workshop here and a single-sided deafness course at this particular moment. But nevertheless, of course, we do the Hearing Roundtable. And this, our 9th Hearing Roundtable, is very, very special, but I want to introduce myself and our group. Hearing is founded about 10 years ago as very special center of excellences. And we are, as you see, a very illustrious but wonderful group of otologists, neurotologists, therapists, scientists, audiologists, and we are all together to bring the world of hearing and audiology forward. We try to teach as much as we can the other colleagues and not to forget also ourselves. And 4 times a year, we have a roundtable like this one. Hearing is a global network of 31 huge ENT clinics. Altogether, we have the experience of more than 100,000 cochlear implants. That's quite a number. And I have the honor to be the chairman of this group since 2017. Hearing is all over the world on each continent. And we are very proud to connect all these different countries and continents together. We are setting the standards since 2008, and we are very, very dedicated to hearing. We are innovative, we bring new papers, we are educative, and we are comprehensive to bring people together at a very high scientific level. Now for this roundtable, which will last about 90 minutes, please quit all programs. We record it, and it's an interactive roundtable, so you also can make questions to us. Please mute your microphone and please name your place so that we know who is asking us and to whom we're talking to. So maybe your name, your organization, and your country. Yeah, comments and questions are welcome. And please raise the hand with the raise the hand button. The whole meeting will be recorded. And as all the other 8 meetings so far, later on, it will be able that you see it on YouTube. This is what we do. This time, we have a very special topic. If you remember, last time, we had electric acoustic stimulation and hearing preservation. And this time, we looked into our fundus of special cases, of curious cases. Actually, we could do 10 roundtables about curious cases, but this time we selected some really cool specialties. Myself, you know already, I'm Wolfgang Baumgartner from Vienna, at this moment Tel Aviv. You know Professor Gavilán. He is professor at the University La Paz in Madrid and the chairman in Madrid with an outstanding long experience. He's also the scientific chairman of the hearing group. Professor Abdul Rahman Hagr, a very good friend of mine. He's the motor of cochlear implantation in Saudi Arabia and the Arabic Peninsula, with really an unbelievable experience of cases in Riyadh. Professor Christen Rack from the University of Würzburg. You know Würzburg, an outstanding university, also some of the homes of deep insertion cochlear implantation. If you remember Professor Helms, and even before, one of the founders of otology, Professor Wohlstein. And last but not least, Professor Piotr Skarzynski from the World Hearing Center in Warsaw, also with an outstanding experience. They do about 500 cochlear implant surgeries a year. And I think this is a wonderful group for very special curious cases. What is new? This time we have a learning standard and we have CME points. So that means for your organization, for your country, you can earn teaching points if you have this number, the CPD standards with the provider number. So these are teaching numbers for your local certification in your country. So this is a fully certified education program, the Hearing Roundtable. And now I pass over, after this introduction, I pass over to the moderator, Professor Javier Gavilán, to Madrid, and I think we will have a very, very nice and interesting roundtable. Thank you.
Thank you, Baumi, and welcome everyone, and thank you for being on the other side of the screen. Welcome to Madrid. Today, the safest city on the world, thanks to Joe Biden and the rest of the members of the NATO summit who has been blocking the whole city over the last 2 days. You know, even though we are recovering normal activity, the hearing group decided to keep our quarterly roundtable, online roundtable, because of the large attendance and the interest shown by the people attending the previous 8 roundtables we had. Today, under the exciting title, Curious Cases of Hearing Implantation, we want to show you 3 different uncommon situations. Over the next 90 minutes, our panelists will share with you some of their concerns in the field of hearing implants based on the learning obtained through these unusual clinical cases. So this is not just the rare case, but what we can learn from those rare cases. As was mentioned by Professor Baumgartner, we'd love to make this roundtable a really interactive activity. So please feel free to participate, sending us your questions or comments using the chat or the audio available in the Zoom connection. And to start with this interaction and show you that we really want you to participate, I will ask you 2 short questions, very easy questions, just to have an idea of the attendance we have now and try to adapt our contents to the audience for future meetings. So please switch on the camera of your phones and scan this QR code you have on the right side of the screen, or if you don't have a cell phone nearby, you can use your laptops and go to internet, enter www.menti.com, and once you are there, you enter the code 3601-6966. If you have a cell phone, it's easier to use the QR code, scan with your camera the QR code, and you will be directed to the 2 questions that we want to ask today. So www.menti.com and the code 3601-6966, or scan the QR code. Once you have it, let's move to the first question of this roundtable. The question is, where are you from? This is very easy. Just tell us what country are you in, and we'll have an idea of the attendance and the areas of the world that this roundtable is being accessible. We have Ukraine. You have Kiev in Ukraine. Spain, Austria and Germany are by far the most people coming from. There's Italy, Saudi Arabia, Egypt, South Asia, Indonesia, Japan. We have more than 100 attendants, and up to now we only have 30 answers, so we still have like 70 people that can tell us where are they from. We have Argentina, Oman, Belgium, Poland, India, Japan, UK, Berlin. This should be Germany also, I think. And we will wait just a little more to have some more answers. And we will move to the second question of this roundtable, which is to have an idea where you were, in which area you develop your work. Are you audiologist, surgeon, student, engineer, speech and language pathologist? or any other option you can give us. So just answer these questions. We don't have too many students, but we have mainly surgeons and audiologists and engineers, more or less same numbers, still 35 answers, and one speech and language pathologist, and others, other occupations are in answered by 4 people. Okay, we have an idea of what's going on with this roundtable, and the Hebrew roundtables are prepared as a journey. We're traveling from place to place, and the good part of the traveling is that we can access remote areas in the world concerning to your location, and we don't have jet lag. So first of all, we will start our trip going to Saudi Arabia, to Riyadh. We are in Riyadh to meet Professor Hagr, which is the president of the Saudi Society of ENT, as well as the Arab Academy of Otology and Cochlear Implants. He's also on the International Advisory Board for the American Academy of Otolaryngology and Hand and Neck Surgery. And he is professor at King Saud University and the director of King Abdullah Ear Specialist Center. He has an enormous amount of experience in the field of cochlear implants, and the hearing group is very pleased to have Professor Hagr as one of our distinguished members. Professor Hagr will deal with a very exciting topic, which is cochlear implantation. It's never too early. Rahman, the floor is yours.
Javier, thanks a lot for this wonderful introductions and for inviting me to share with you the experience we have in our center. And I would like to show you what we are doing these days and how early we activate the external sound processors. And we think it's never too early for these activations. And we'll start with this case. This patient who's here lying down on the table of the operating room is a 29 years old man who had a road traffic accident, and 2 weeks after intubation he started to wake up slowly and find himself deaf mute. See, he lost his vision completely and he lost his hearing, and he came to our center 3 years after this accident, and we talked to him about possibility of hearing after cochlear implants. Without hesitance, he agreed immediately, and in spite of good counseling that it may not work. And he said, I would rather die on the operating room, but not to continue my life like this, deaf and mute. And for 3 years, he developed a miracle by communicating with his brother by just tactile sensations, okay? His brother is a policeman, and he is the one who's standing here. This is the only time we allowed patient relative to be in the operating room, because he's the only one who can communicate with him. And I would like to show you the video and see how they communicate with each other. So he had surgery, which was not the easiest surgery. It was somehow difficult putting the electrode in fractured cochlea. And he came a week after to have his sound processor activated. And we said, no way, you are a difficult case, and we want to make sure 100% there is no chance of any complications. He said, doctors, I'm not waiting anymore. I want my sound processor now. So we could not say no to him. And this is him came a week after to our clinic and got sound processor activated.
سلطان كيف حالك؟ عرفتني؟ أنا مين؟ أنا مين؟
So he has completely different life after cochlear implants, okay? And he is the one who's inspired all of our team to think about early activation of sound processor. So we started pilot studies of 5 days activations, and we found it a wonderful experience, and we published it already. So this one took us to a next step with this process. So we thought about it a lot, and there is a lot of advancement in the CI technology, surgical technique. A lot of things change over the last 40 years, but the only thing which did not change is activating of the sound processors, which most of the center between 3 to 6 weeks. And it's different across different clinics. There's no standards of this time. And we thought, why not to activate it earlier? Because there's no contraindication for that, okay? There was somehow relative contraindication for early activation when we used to do this big incision, shaving half of the head, but not anymore these days. Most of the center would go with the small incision and hardly any swelling, hardly any things next day after cochlear implant. The reason for big incision, we used to do a suture fixations. But these days, everybody almost using the subperiosteal fixations. And with that, we don't need to have this big incision for those sutures. So for us, and for a lot of patients, it did not make sense why we are waiting for 4 weeks, okay? It costs a lot for the families to come for second visit to the centers in Riyadh. And it's a lot of time and waiting. And for a lot of patients, does not make sense. It's a lot of emotions. They would like to see if the surgery was successful or not. It's almost the same thing we hear in the airport. For your safety, there is a delay of the flight. And for everybody, that does not make sense, okay? So we moved to the next step, and we start activating the sound processor next day. And we do it nowadays for all of our patients, even children, bilateral simultaneous cochlear implants, almost all of them will end up with next day activation. And we look to the long-term effect of this, and we found there is nothing really stopping us from continuing this process. In fact, we moved another step, and we start to activate the sound processor the same day of surgery, okay? A few cases, they end up with cochlear implant under conscious sedations, and some of them are completely awake. We published this paper, and those patients, we activate the sound processor the same day, and they go home same day hearing. This is one of our patients. He's actually our colleague. He's an ICU doctor who were not able to continue with hearing aid, so we went and did for him a cochlear implant. I would like to share with you the video here, where is he negotiating with the anesthetist about the medication and the dose he would prefer.
This is infusion we are doing, 16 microgram per hour. 16, 16. 4.16. 4.16 milligram per hour.
So you could see me here doing the mastoid drilling, and the anesthetist is talking to the patient and see what kind of medication he would prefer. And he's almost completely awake, and I'm doing the cortical mastoidectomy. And here when we put the electrode. He was completely awake. And here you could see on the monitor that the electrode is fully inserted. This is him after we finish surgery. So here, so we activate it and he's hearing. So you could see here, we moved for early activation from 5 days to 1 day to the same day fitting. And in conclusion, we think it's never too early, but cannot be too late anymore, okay? And it's never too late to start early fitting, and it is always too early to quit. Some people, they have some issues with early activations, they quit quickly, but there is always an issue with everything, and they need to be patient and see how they control these issues. And if it's not now, when? And if it's not your guys, who will do it? And we think there is a synergistic shyness between the audiologist and the surgeons. The audiologist concerned about surgical issues, the wound healing and infections and so on. And the surgeon concern is about the mapping and the magnet. But if you ask the surgeon, they will be extremely happy with the wound next day. And if you ask the audiologist, they are extremely happy to activate the device next day. So I think that would solve all the issues. And the other thing would solve the issues if we remember the father of tonotopicity, the Bexley, what he said: if we want to make a discovery, we have to take a risk, since everything new was discovered by accident or by the fact that somebody took a chance and went ahead when there wasn't 100% safety for the solutions. And I think for all the options we have no 100% safety, including the early fitting, which I advise everybody to try it. Thank you.
Okay, thanks, Rahman. Very good. I really enjoy your talk, and I enjoy the concept you are proposing. If you ask me, would I like to do this? I would say, no doubt. I would like to try this, but I would like to start the discussion. We have 10 minutes for discussion, asking Kristen and Piotr, would you like to do this? Just a short answer to start the discussion. Kristen.
Like, we have tried it in some patients to do the activation, let's say it after 2 or 3 days, but somehow these patients did not adjust so good to the early activation. Especially we saw in some patients some impedance changes later on, because we saw them quite more often, and then the implant was somehow too loud or somehow misadjusted. So I think it's a good idea, but maybe we have to take this into think about how we do with these positive changes in the cochlea, these impedance changes, how we can adjust to this.
Piotr.
I will tell on that way. I will never do it in children because I don't suffer from impedance. I suffer from healing and hematoma. If we connect it with the processor and the process, and there is some, I put quite often a vacuum over the implant to make better suction and better healing. I did it sometime in that when I have really dry situation, absolutely no bleeding, just to see how it works, especially for patients coming from abroad and they would like to go earlier. And in adults also is the same situation. So if I have good healing, no problems, dry, no problems with the skin, good suturing, good position of the implant, I could do. If I have some doubts that it will make for some change in implant position, I prefer to make good packet and to have better healing and better implant position than early activation. But from theoretical point of view, we did it sometimes, and it worked. Even if we fit that, I recommend to wear the processor a little bit later, because it could later make some hematoma. I can tell you why. We had obligation from our reimbursement issue that we need to give to the patient the processor, and they try to wear it. And if they wear it, in some cases we had hematoma in children. That's one a little bit skeptical, especially in small children. But we are in Poland, we have a little bit different weather than in Saudi Arabia. There is more dry, so maybe there is a little bit different. You know, it could really happen.
Okay, we have a comment from the audience. Can you please turn on the microphone of Professor Hagr?
Maybe now,
Yes,
maybe now it's working.
No.
First, congratulations to Abdurrahman. Excellent talk. I liked it very much. But remember, in former times when I started with middle ear surgery, we had 90% in local and 10% in anesthesia, and we completely switched this because patients do no longer want to have local anesthesia. They prefer general anesthesia. So is it different in your country? This is my first question. And the second is similar to Kristen Raag. Did you notice some differences in performance after the early activation in the course of time?
Rahman.
Yes. Can you hear me?
Yes, very well.
Yes, thanks a lot for those wonderful questions. In reality, in Saudi Arabia, we give all the adults the options of having cochlear implant under local anesthesia. And to tell you the truth, this was not attractive for a lot of patients. Even if you ask me, I would rather go for CI under general anesthesia. But this is an option. We give it to the patients, and tell you the truth, most of our patients who wouldn't end up CI under local anesthesia were male. We have only 2 females, and one of them we quit in the middle of surgery and went for general anesthesia.
Which is not nice.
Exactly. So I think it's an option. We give it to the patients. Tell you the truth, we find no different for a surgeon when we do local anesthesia. We have good anesthetists who sedate patients sometimes, but I think it's an experience that maybe we're gonna need it for a few cases in elderly with a lot of comorbid disease. That would be another option that instead of saying no to them for cochlear implant, I think we could do it with the local anesthesia. For those local anesthesia, almost all of them, we do same day fitting. And the nice thing that they have a wonderful experience when they start to hear immediately. We followed those cases closely and we're monitoring them. And tell you the truth, we did not really found a case that stopped us from quitting this program. Rather, that kind of technique actually get us a lot of referral to our center. So this is another thing that gonna keep you extremely busy if you announce that you do these kind of early activations. Okay. Some of my friends.
Rahman.
Yes.
Just to, because we are short of time, just to make it clear, it's 2 different things. It's local anesthesia and early activation. Let's focus on early activation, which is your case.
Yes.
What are the complications of early activation?
Well, there was not a significant complication that stopped us from doing early activations. Okay. Almost the same like late activations. There was no issues like with the wound healing or with the programming, which required to be changed, or few cases they require the magnet to be strong at the beginning, but later on they go with the usual magnet they would require. So nothing actually stopped us from early activations. It's almost the opposite. We get more cases who are interested in this activation.
And what are the the consequences of what Professor Skarzynski was mentioning, changes in impedance, changes in the way you organize, you program this early activation. What happens if there are changes in impedance?
Actually, we published it already. It's one of our paper where we publish the impedance, and we found that there's no much of a significant effect of the impedance that would affect the programming on our patients. So it's already been published in the literatures. And this is another thing we were thinking about it. Is it gonna be affecting the patient, or patient will have loud sound with the time, and then they will reject the cochlear implant? It was not the issue.
And my final question before we move to the next presentation. Can you do this always? I mean, children, adults, men, women, or there are a subset of patients or situations where you will not say, what you will say, I will not do an early activation?
The most important things that we don't do early activations for cases who are not interested in early activation. So still we have few cases who said, no, I don't want early activations, okay? Or few cases where the revision cases, infection cases where we revise the implants, those we don't usually give them early activation. But the otherwise, it's an options, we give it to everybody, and we did not really have a major resistance to this option.
Okay, well, it was great. But we have 2 more presentations, and now we will continue our journey from the desert in Saudi Arabia to the green Germany in Würzburg. And we are here in Würzburg with Professor Hagr, as you saw in the question, but our panelist today is Professor Kristen Rack. Kristen got promoted to professor some months ago, and right now he is the head physician and ENT specialist in the field of cochlear and middle ear implants at the University Clinic of Würzburg. The hearing group is delighted to have Kristen Rack as one of our active members. And Kristen is going to deal with cochlear implant and enhanced imaging. Kristen?
Yes, I will share my presentation. Yes, hello everybody. Javier, thank you very much for this nice introduction. I will talk today about a curious case of hearing implantation, which was somehow the topic of this hearing roundtable. And I did my presentation like a short quiz, and maybe we can discuss in between a little bit about the questions I have about this case. And I will just start with this case with 2 images. This is a special case, and here you see now the 3D reconstruction of the head of this patient. You already recognize that there's somehow different. You have this hyperostosis of the mandible and all this of the bones. The nasal bones are also widened. This is like from outside, it has some differences, but especially if you see from inside, you see this massive hyperostosis of the all the cranial bones, and narrowing the optical nerve, narrowing also in the inner ear canal. I will come to this later. I have to admit, I did not know this disease before we saw this patient, but so my question is, does anybody of the panelists and maybe also of the other people attending this meeting knows this disease?
Do you have any one of you, do you have an idea of what this can be?
Is it Paget disease?
It's linked. When I read about this disease, it's linked to this, yes. It's in the same area, yes.
Go ahead, Kristen.
Yeah, I will go ahead. It's called cranial metaphysical dysplasia Cmd. It's a really rare genetic bone disease, less than 70 cases described until now. And this has a progressive diffuse hyperostosis of the cranial bones and also with facial dysmorphism. I took out these pictures from a paper describing this disease. Our patient is male, but it's somehow similar, his vision. And again, to the facial dysmorphism, there's also a widening of the long bones. It can be autosomal dominant or recessive, and mostly there are mutations, the ANKG gene, it's a non-organic pyrophosphate transport regulator gene. But would like to ask, what do you think, what autological symptoms could these patients have? What has been described in the literature regarding this?
Who wants to answer? Piotr? Rahman?
I think I have seen one case like this, but was like long time ago. So I'm not sure my memory is good, but I think they could have all kind of hearing loss, could have a conductive hearing loss with this growth of bone blocking the canal or affecting the ossicles. They could have a mixed hearing loss, element of conductive as well as sensory, as well as these bones affecting the cochlea. And they end up with sensory neural hearing loss. And the other thing, they could affect also the nerve in the internal auditory canal. So that would be another issues that cochlear implant may not be the best solutions for them. So this is, I hope my memory is still good.
It's mostly right. Yes, it starts with conductive hearing loss or mixed hearing loss. We saw the patient from his about 10th birthday on regularly in our clinic, and that was the audiogram in 2001 at the age of 10. Then this was at the age of 15, so a progressive of this mixed hearing loss. With 20, there was even more progression. 25, high degrees of mixed hearing loss, and last in 2020 when we saw him, not the last time but for further decision, there was nearly a deafness, highest degree of combined hearing loss. So now then we performed more CT scans and would like to show you a little bit more of these autological symptoms. Here you see this hyperostosis and also that there's no mastoid cells anymore. And so also a narrowing of the outer ear canal, and the middle ear space is nearly totally gone. There's no real middle ear space. The cochlear seems to be also somehow narrowed, and like we heard already before, also a narrowing of the inner ear canal. But this bone disease really impacts all the internal head structures. In the MRI scan, you can see that also the area of the brain is like minimized, so the brain is all packed into the skull. Here there's nearly no cerebral spinal liquor anymore around, and here it's again seen that the inner ear canal is also really narrow, and the labyrinth looks quite normal until this time. So this was his situation with his hearing aid. So he wore normal hearing aids. On the left side, there was a not so good function. On the right side, there was a little bit better function, but because of this narrowing of the outer ear canal, he could not really wear his hearing aid on the right side and was nearly functional deaf, I have to admit. So what do you think in this way, what therapeutic options would we have?
Let me ask you something.
Yeah.
Piotr, you want to say something?
No. I remind the case which I had, and similar, it patient looked like that, but really during 10 years there was no progression, and I put the bone bridge in such case, but it was exactly when I looked for your results, the patient is 2 years after bone bridge, and it was 10 years stable history of the bone conductive threshold, because I always suffer from decrease of bone conductive thresholds, and when I see that, you know, the bone bridge is not good indication because it decreased, of course, and then there is no chance for activation.
Yeah,
that remains for.
Okay, the question, Kristen, hearing loss is progressive, right?
Yeah, it's progressive.
And did you perform any, is just a general question, did you perform any kind of genetic testing? May genetics help with this case? Before going to the therapeutic options, just diagnosis?
He has been diagnosed, and also in his case, there's one mutation of this gene family I showed before, that this has been confirmed in his case. It's a recessive case, so there's no other family members affected by this case.
Okay, so bone conduction devices have been ruled out by Professor Skarzynski. What else can you think about, Rahman?
Well, I think this is not a straightforward, easy case, and I think we should give the patient the maximum benefit of doubt. Remember, this patient most likely gonna end up blind, affecting the optical nerve with this bone growth. So the only way of communication could be in the future for him is the hearing. So I think with this profound hearing loss and no benefit of hearing aid, I think we should give him the benefit of doubt and do the cochlear implants with the good counseling for the patient that this disease could affect the auditory nerve and they could lose the hearing after, in spite of cochlear implants. And I think after that, maybe the only solutions will be the ABI.
Piotr, you agree?
Yeah, if you are in Turkey, probably straight ABI without doubt. I would like to do CI as fast as possible till I have good orientation through the external meatus, because probably it will be very difficult to go from posterior tympanotomy with a little bit not good orientation, and then sometimes elevate the flap from the posterior wall to know how deep I could go and, you know, to not do much damage, because probably the orientation for the facial nerve canal could be really difficult. So this is why I go for CI. And probably we need to be ready with probe electrode, because maybe it could be not full insertion because of some issues in the cochlea. So always be ready to have on the stock, you know, 24, 26, 28, to not to, because sometimes it could be too shallow insertion. Even in CT looks quite good.
Yeah, that's probably, we did the same discussions like you in our clinic before. We talked somehow also with a neurosurgeon about an ABI, but they think with this thick bone, that's gonna be a really big issue for them finding the right space and also entering the lateral recess for the ABI. That's gonna be really difficult in this case. So we went forward to go for cochlear implantation. We did, like we always do, did the planning with the Autoplan software. You can see here that it's quite a small cochlear, 31.9 millimeters. So quite a small cochlear, and we did this planning with Autoplan software, and we came out with a Flex 28 electrode in this ear. And now I would like to show you a little bit the surgery performed by Professor Hagr, and he did, like we've discussed already, the access through the outer ear canal, slowly widening the outer ear canal to get better access to these deep structures. And then we went a little bit more cranially to be safe in this area, like we've discussed already regarding the facial nerve. And then more further in the depths, some space could be identified. And then in this space, it was then possible to detect some remnants of the tympanic membrane, scarrings, and also the ossicles could be detected. Then the middle ear was further exposed, and then something happened. What it's more or less what can happen probably in all cases of cochlear implantation. If you have this situation, and this, I would like to show you again the CT scan, and maybe the experienced surgeon will see what is a really risk in this case here. Again, from the beginning, you can see it quite clearly here. He had a really high jugular bulb, but we had to prepare in this area. And then what happened is an opening of the jugular bulb with lots of bleeding. And then this bleeding could then be stopped by adding Tabotamp and Tacosil. A combination, it took nearly an hour, nearly 1.5 hours to solve this problem, but finally the bleeding could be stopped. And then the tabotamp slowly been taken out. That took again an hour, more or less, slowly working. And always, like you see it here, it's really important to always soak again the tabotamp to get this, to get it out again. I think that's really good for all cochlear implant surgeons, also the beginners, that they've seen this once, because probably this can happen in ear surgery and all the cases of cochlear implantation too. So I think it's good that we can show it here. And then finally the promontory could be exposed. Then we see it in the next a little bit better. So here are some remnants of the ossicles, and then the cochleostomy was performed.
Christian,
yeah,
no windows were seen.
The round window could not be detected. So here, but it was a good access to the cochlea. You see the basilar membrane, so both scala could be then achieved, and then it was without problems possible to insert the Flex 28 electrode at this ear. And then afterwards we did a closure of the external ear canal, took away all the skin, and the patient, the wound healing was without major problems.
And facial nerve was not an issue?
No, we did not like slowly, but we did not encourage the facial nerve. We used facial nerve monitoring, but the facial nerve was not accessed. We saw it also in the postoperative CT scan that there was some little space to the facial nerve. But we have to admit that going through the outer ear canal, that's probably the higher risk is probably affecting the facial nerve by this access than to affect the jugular bulb. Then here you can see is posterior TC scan, so a nice insertion into the cochlea. And now I would like to ask, do you think this patient has benefit from his cochlear implant?
Rahman.
Well, I think usually cochlear implant give us a lot of surprise, and we see a lot of good result from cases that we doubt all the time. So I think I'm very optimistic that this case will benefit from cochlear implant. Besides, it was done by the top expert surgeon in the world.
Piotr.
I think it would be beneficial, but sometimes we need to have some time for some fitting. Sometimes there is issue of stimulation in the cochlea, and some areas are not effective from the stimulation. So sometimes Professor Lawrence and his team is playing with, different size. And the issue here maybe could be the facial nerve stimulation also. So I would like to turn off the basic 2-3 channels at the beginning to not to stimulate, because it sometimes in such cases could reflect in some facial nerve stimulation.
Yeah.
Well, I have no idea about the benefit, but I'm sure that this may work better than in ABI in these patients. So I think you took the right solution.
Yeah.
Go ahead, Christian.
Yes. So for the benefit, so this was 3 months after activation. So already 40% of monosyllabic word speech understanding. The patient was from the first activation really happy. He wore this cochlear implant every day. And this is now the situation nearly 1 year afterwards. So nearly 100% of monosyllabic words, really happy patient. And he could take over a new job. And now you can see here's the left side with the hearing aids still worse. And yeah, we did the cochlear implantation of the second ear 2 weeks ago. And here you can see also a small cochlea. So we ended again in a Flex 28 electrode when we use the Autoplan software. And you can see here again this nice inserted cochlear electrode into his cochlea. We have not did the first activation. Maybe in this case, an early activation would be good. The patient would have liked it to do it, but we have not done it yet. But now I would like to talk a little bit about what Professor Hagr have already talked, because will these results be stable? That's really a problem probably in this case, because in the literature there has been some, okay, and maybe I asked before you, do you think this going to be stable? This
First, let me, Christian, let me ask you something that is in the chat. They are asking if concerning the surgery, and before going to the stable benefit, if the use of navigation system would have been a good option for these cases, for a case like this.
Let's say, in my opinion, it could be, but you know, navigation and lateral skull base, it's always a little bit difficult to find the right markers for registration, maybe putting screws around the mastoid, doing another CT scan. This could have been a possibility, but as we've really followed the outer ear canal and we knew the CT scan, there was some distance from the outer ear canal to the facial nerve. So we knew that there's some space. We were aware of the jugular bulb, but in this area we had to prepare. So it could have given more, maybe more internal safety, but I think in the end this worked good, but it could be an opinion, yes.
Okay, so what about the benefit, long-term benefit? Rahman, do you think this is going to last forever or just for a couple of months?
I think it's gonna last longer than if we don't do a cochlear implant. I think this kind of implant will work like a stent on the cochlea and prevent a bony growth inside the cochlea. So we are really preserving any cochlea for any more destructions. The only concern in my mind for such case, by the way, it's a wonderful, wonderful case and done in a wonderful way. The only concern is the internal auditory canal, bony growth in this area and affecting the postcochlear as a postcochlear lesion, and that would be the concern. But putting the electrode inside the cochlea, I think this is a wonderful way for having a full insertions and protecting the cochlea from any more bony growth.
Yeah.
The other long-term results.
Probably it could decrease in future because of some ossification of etc. But you know, I think this is the best solution. I absolutely, the benefits from ABI there are. We've seen that there are some very nice cases, but in majority, if we look as a big group of patients in the benefits in the CI, always if we could do CI, we do CI, and that the results are better only in the case when there is no chance. Even after some trauma, when there is any suspicion, any answer in any ABR that there is something, we do ABI. So in that case, absolutely CI, and I think it will be better.
Well, I agree with them. I think my main concern will be the internal auditory canal. I mean, I don't think the cochlea will be the problem. The problem will be if there's a bone growth around along the internal auditory canal. But this is the best solution you can have. I mean, the other solutions were just theoretical options. Christian.
Like when I read all the literature regarding this this disease, that's also concerned. And there's one like case report where they did a decompression of the inner ear canal in a patient with progressive hearing loss. It's already from the 80s, so it's a little bit longer, and probably in these days when there was no when you did not do the cochlear implantation in this case. So maybe, but it's good. We will have this patient in our post-implant program and see him now regularly, and probably after then a year and a 1 year base. And then we will see how this case will develop, and probably he's a really smart guy. He will probably also report when there's a deterioration of the hearing.
Great. Well, something else from your side, Christian?
No, that was this case I would like to wanted to present you, and I think it was good to do a meanwhile discussion regarding this case because we came up with really interesting thoughts about this. But I think we are still open for discussion for the audience.
And are you aware of more cases like this one, the same syndrome, having cochlear implants in the literature?
There's a publication of one case, but it's of I think a 60 or 70-year-old man. So there is differences in the progress of this disease. Yeah, this really depends on the genetic situation, but with 70 cases, it's really difficult. This is, as long as I read the first report on a bilateral publication, and I think when we've stable results, probably we will also try to publish this as a case report, something like this, because it's an interesting case also to learn the progress of this hearing and what can we achieve with a cochlear implant.
Okay, thank you very much. Let's move to the next presentation. Let's keep our journey, and now we're going from Germany to Poland. And we're in Warsaw, in Poland, to meet Professor Skarzynski, which is a specialist in ENT, both in adults and children, audiology and phoniatrics. He develops his scientific work in the World Hearing Center of the Institute of Physiology and Pathology of Hearing, the Institute of Sensory Organs, and the Medical University of Warsaw. 4 years ago, he became the Director of Science and Development at the Institute of Sensory Organs, and the hearing group is very happy to have Professor Skarzynski as one of our vice chairman and one of our most distinguished members. Piotr is going to deal with a very exciting topic, which is intraoperative cochlear monitoring. Piotr?
Javier, thank you very much. And at the beginning, I would like to thank for invitation, and I would like to underline for all our people who are today with us. The hearing group is a wonderful group. It's my favorite group in terms of exchange of knowledge. I always remember different meeting discussion with senior surgeon experience. I always remember, like we have Professor Hagr today discussion many years back about some surgical issue and other members, which changed our minds, and we always support each other. It's a great opportunity. So it's good that we are here. And I would like to tell about topic. I will make the presentation. I would like to talk about topic which is, how to say, quite maybe not controversial, but interesting. You know, the issue there is the intraoperative measurement. So that work was performed together with audiologists. So with Professor Lawrence and Marek Polak, they inspired us a lot. And if you are a surgeon, if you do your surgery, you know, always all the issues related to measurement are, you know, sometimes they take a long of time. Sometimes you are thinking, is it good or not good? And sometimes they check how you do the surgery. So if you are not as experienced, sometimes at command, they will see how I do the work. And, you know, and at the beginning, I ask, okay, what will it change in my surgical approach, and our surgical approach? And honestly, the answer was that it has changed our attitude. Even we developed with my father and the other people on the team about the partial deafness treatment. That work about the ECOG has changed our attitude to some things that I will tell you which one. So the case, we did many cases like that, a lot of cases with partial deafness, but I would like to focus on one which is quite interesting and a little bit different than others. 47 years old male, so residual hearing in low frequencies. It was Sonata 2 Flex 28. We do all of kind of implants, but Sonata 2 was chosen in that case. And intra-ECOG was performed. So it looks like that. You can see the hearing preoperative, which was quite similar, like 1 month post-op. And 3 months post-op, you can see that there was slight decrease. So there was some functional hearing, which was possible to amplify through acoustic solution later, but it's the hearing which we had. And how looks the system. So the ECOG was performed with the device from Medel, and the recordings we performed the implant back telemetry measurement system. And the novel SPL chirp signal was used, which was developed in vivo. It's honestly for surgeon maybe it's nothing special, but it's really something new. And it was duration of that was 12 milliseconds, and we check it at the octave frequencies, especially of course interesting for us. The frequencies was 250, 500, 1000, and 4000. So it's in other words, it was a very simple solution. It was connected, of course, through the sterile packet to the processor. So after implantation, you need to have good placement of the implant. It's good that subcutaneous tissue is not so big, but you know, also we can take the device outside. Another issue that we assess in the autoplan, that the device should be 28. And honestly, quite often, if we estimate with autoplan how deep should go insertion, we do it as in that, but sometimes shorter sometimes could be better. So sometimes you have to be a little bit skeptical about some evaluation, but we observed that it will be 28. And initially we wanted to go to 490 degrees, but it went for 265 degrees after the CT scan in postoperative was presented. So it looked like that. If one thing which we learned in terms of resistance, I always must be sure that if I, for example, put the electrode in a residual hearing, the entrance of the round window of round window extended approach, or in the worst case cochleostomy, which is very rare, is at least equal to the electrode size. So I took the steroid on 0.8 suction and I check if is it possible to do this, because if it's too narrow, if you put that, you could have resistance because of narrow access. So if you have too narrow round window opening of too narrow round window extended, sometimes it's also could be the totally different issue, which is not topic of the presentation. So the entrance must be good, not too small, not too big. And what was noticed, we knew from earlier that one of the crucial moments for the hearing preservation is not only insertion, because if we did the proper nice insertion, something which we underestimate, honestly, were two moments. First was release of forceps, when we changed from fingers to forceps, and from forceps later to change the position. So forceps was a little bit, in different place to put the electrode inside. And second was the sealings, was the packing. It really, in the ECOG, in a lot of cases which we did, there were some issue. And the worst case is if you have not a good angle and you put the electrode inside, it curved a little bit and you released forceps. So then you could see the moment. To present you what we see in that case. In the red, there is 0.25, in the yellow is 0.5 kilohertz. So something which should be important, the higher there is signal is better. So you put and you see in the middle right side, you can see that waves. Waves means that you will have response. So you can see in how many contacts we had very, very nice response. It was reflected to the audiogram which we had. And in the yellow, we see it's constantly increase, better than the 0.25. In theory, it should be a little bit different, but it should be red, it should be over the yellow. But you can see that the stimulation was great, and the forceps were released, it decreased. And then there was high resistance. Then there was question if the resistance was because of insertion and the electrode started to be not as narrow, so went to 0.8 millimeter, because the flex 28 is a little bit, of course, in different diameter at the basal part. And there was release of, and what was the resistance was analysis of that, and the forceps were released. So you can see that it has changed that after that, and 0.25 were later better than 0.5, the response. In general, should be different. 0.5 also should be very good, but it means that it worked like that. What I can tell you about that, you can see in milliseconds. You can see in seconds. You can see what was important. You can see on more in bolded which are elements of the electrode influence in the results. So what I can tell more, when there is releasing of forceps, it could be problematic. So we really started to put more and more attention for releasing the forceps. And in practice for otosurgeons, I must be sure that the posterior tympanotomy is as big that I could push the forceps till the end of insertion. So I could put on the one keeping the forceps, sometimes I could put the forceps and release them one time, not to switch. Sometimes it's impossible because we need to a little bit push the electrode, but this is the moment. So we a little bit enlarge posterior tympanotomy is the second thing. And the third, there is the sealing. So the sealing also should be delicate. So we need to be really careful in that moment, because that moment could reflex. What's more, even if we honestly lost signal in ECOG, so it was, oh, come on, we lost signal. After that, after a period of 1 month, for example, we had hearing preservation. So sometimes that insertion could make a little bit stiffened the maybe basilar membrane. So if you lose even sometimes signal, it doesn't mean that it's lost for all. So this is some learning which we all observe more and more. So this is quite a lot of interesting findings, which really honestly influence in that. And also there is very good tool which shows us how is it going. So The echo could go, and it is smaller, is faster, is more, let's say, friendly for surgeon. Of course, it's a demanding tool because of the monitoring, and we monitor our work at the beginning. But if you do this for yourself, sometimes you can even you are a very experienced surgeon, and my father is quite experienced surgeon for many years. He started to think, okay, I could a little bit change something because I could be better. So it's good to have such mindsets. This is my conclusion, and I would like to thank Marek and Arthur and the team for really, very good brainstorming, which could influence for increasing the results, and which are quite good to make even much better in the future. And I'm happy that I could share with you about our experience that today. If you would like to read more, there is the very fresh publication in the live. It's free of charge, it's open access, so you can read all the details or the technical elements if you would like to do this and how it's influenced. So we are happy that it was published in open access journal. Thank you very much.
Thank you very much, Piotr. It was a great presentation, and I'm sure we will have a lot of discussion. But I would like to start by taking two questions from the audience to Kristen. Are you there, Kristen?
Now I'm here.
Now you are here. Okay. There's one question asking, how was the impedance fluctuations over time with this patient?
Here, in that patient, in the impedance...
No, Piotr, it was for Kristen concerning the previous case. Okay. We will go back to you in a minute.
Okay, sorry.
I have to admit, I do not have the this data now.
Okay, and the second question is, did the patient complain of tinnitus post-implant and activation of sound processor?
No, there was no problem by this patient, yeah. He had no tinnitus before and nothing afterwards. So there was no, probably no problem with the vestibular function either. So.
Great. Okay, so let's move to you, Piotr. Well, let me start by something. I don't have any experience of intraoperative monitoring during cochlear implantation, but we had some experience of intraoperative monitoring of hearing during acoustic tumor removal. The problem with intraoperative monitoring of hearing during acoustic tumor removal is that once you saw deterioration of hearing, it was too late to prevent the situation. I mean, it's not like the facial nerve monitoring that you touch the facial nerve, it beeps and you stop and it recovers. When we had that during intraoperative hearing monitoring during acoustic tumor removal, the moment you saw the event, it was too late. Is this the same with cochlear implants?
Javier, I also thought the same, because I did here and more, I did it with Slim J electrode, with advanced bionic. And then I thought, come on, I lost, you know the feeling, you're the surgeon, And then, we observed that patient and it was not as bad. If we lost, sometimes the signal started to increase. And when I saw the signal started to increase, I said, okay, we'll wait. And sometime, in one case, we were waiting 10 minutes, to see, and we observed the slowly increase. So at the beginning, I was very sad, and when I lost, I said, no, it's a disaster. But after some experience, now I'm not so dramatic when I lose. Of course, I don't want to lose. I see decrease. What is key issue? If I hear from the audiologist that there is decrease, I stopped immediately. I stop, have the forceps. I said, okay, slowly, and think. As you see, there was some seconds. Okay, go deeper, not go deeper. From where is the resistance? Okay, I need to check if there will be not some migration of the electrode. And I start asking to the nurse, okay, give me some periosteum with the fibrin glue to seal. You start to adjust you need to be agile. Adjust your decision. I have my audiogram. So if I lose in the 2 channels out, if it will be good result, there is a lot of brainstorming in each case. So now, I tell you honestly, after that, because of that loss, in each case, when I do CI now, my most important issue is which access I will have through the round window. And always you don't know how it will be. So I always want to be sure that I will have proper opening and I do more round window extended. So even not round window, but I take more bone overhang to have more space and to be more, adjustable, that the electrode will be not carved during the insertion at the end, especially in the end. sometimes I take shorter solution than the auto plan says us. Sometimes, you know, I take 2 millimeters if the patient is younger, because younger patients are a little bit better. If I see, I had discussion with Marek Polak and Artur, if I see the patient that there is really progressive hearing loss, there is residual hearing on the really border, I said, guys, we go deeper, you know, if we lose, it happens, but we will not have the solution later. So we put the deeper insertion. But honestly, after that ECOG, I had a lot of minds, you know, when I do each surgery, how to, you know, change that, something what was for me very obvious. So as for the question, if you lose, it doesn't mean that is end. It's
gone forever.
Yeah.
And did you see any difference in stimulation, in recording the stimulus, hearing stimulus, before and after opening the inner ear? I mean, opening the wrong window or doing a cochleostomy. Is there any difference? Is there any, because I saw a lot of events related to the forceps, but before inserting the electrode.
But, you know, the recording is going when the electrode is inside. So, you know, before you have no, you know, you put the electrode and you start to see the answer when the electrode is inside. So, no, before you have nothing. So in that I cannot. If you do EABR or something, you know, you could think, but no. In that case, you have responses when you open. So when you open, when I open, I put the electrode inside, and then I see the responses which could change. I didn't before. Not I, you know, I think in no one case there was no cochleostomy was never here, but it was in some cases really round window extended. And in one case, there was, let's say, too much extended. So there was drilling, you know, went through the membrane, and there was a response in that case. But from the beginning, there was decreased amplitude. So it was a little bit worse, and I was skeptical.
So you cannot do surface ECOG, like putting an electrode on top on the promontorium and recording before inserting the electrode. No.
There is an option, but in that case, you receive the answer from the electrode. So
okay. Rahman, do you have any experience? Do you think this is something you should do? Do you think this is you will never do? What do you think about?
Well, in Saudi Arabia, everything is different. You know, the temperature here is 50 compared to your guys in Europe. And we face a lot of different issues in Saudi Arabia. For example, we looked to the cochlear duct length, and we found we are Saudis having short cochlear duct length. So we end up with the shorter electrodes. We found that the facial recess in Saudis are extremely narrow, and we go sometimes with one diamond to open the facial recess, not to traumatize the chorda or the facial nerve. So I think your guys are extremely lucky with the weather, as much as you are extremely lucky with the cases doing for them cochlear implants. And most of our cases are profound hearing loss. We do also few adult, but not as much as we do children. So the situation is somehow different. We did few cases with the ECOG, but we found it time consuming and really did not see any effectiveness. We see efficacy on the monitors, we see efficacy on the parameters, but the effectiveness, the outcome on the patient, we did not found huge outcome. So maybe because of the smaller size we are having, may not be as much as the wonderful programs in Poland. But I think this is a wonderful experience. So I think soon we're going to adopt it.
I have a question from the audience concerning robots. There's a lot of talking about robotic electrode insertion. And the question is, do you believe that robotic surgery can have a place in the near future concerning the less traumatic insertion of the electrode?
Oh, you know, robotic issues making me a little bit nervous, because I tried to make the program earlier, and the bioethical committee really made, you know, that there was time for scan, for preparation, that with all that time, when I prepare robots, I could do 10 CI, you know, so it's still, and, you know, that's why for me, it's not a big issue, but, you know, I understand what's going on with the companies. I understand what's going on in the future in the low experience surgeon, as the robots are somehow of the way. And this is the question where robots could find the place. We have several robots, and when in the insertion, might suffer from that. I discussed it with Veda Topsakal, who, working on Hero. There is the issue that you really must to have good angle, because if you have not good angle, and you'd really, if you have nice posterior tympanotomy, you could adjust the insertion. So if you have a robot with not good, angle, then you could make not good insertion. Then this is the jeopardize the results. So there is the disadvantages and advantages. Second is that if somebody has shaking hand, and you put the electrode, you have the issue. That something what suffers me with robots in that case, in Flex 28, is that the most often the electrodes bend at the end in the last 3 electrodes. And if you put the robot insertion, and if the electrode will bend, you have how to, if you are in the mastoid, in the middle ear, you have how to, make contra to put the electrode. And this is something which it is bent, it will be bent more. So there is a lot of issues which need to be worked. Of course, according to the policy of European Union and others, we need to think about robots in our practice. I'm 40 this year, so I think till my pension retirement, robot probably will come in 25, 27 years, but maybe not as fast as we expect.
Christian, you're a young guy. You should be robotic. What do you think about that?
Like, my opinion is similar to Pat. I think this robotic system with drills through the posterior tympanotomy, you do not have to do the mastectomy. I'm not really sure if this is gonna be the way to do it in future because of time, because of safety. But I think I've seen some systems which can do a really slow, controlled insertion, although this problem with this bending electrode might be a system, but there are some systems who could do an insertion over days, like really long time insertion. And there are quite data which have been shown that especially this shaking, what we do, a human cannot really do a straight insertion. We do a small insertion, then stop, do a small insertion, stop. This can be measured in this might be the problem, because then we have really high pressure changes, and a robotic system could help to solve this. I would also like to comment on the ECOG, what we have seen before. Like, we have also tried it not too often, but I really like to have my own vision on the like the results. So we have this digital microscope, and then I can see myself, I can see in the screen these wave changes, and this can really help you to then you are even faster to stop your insertion than if an audiologist tells you, oh, now you have to stop, and you say, no, at the moment I have not done anything. This happens, like also in acoustic neuronoma and all this stuff. So if you see it by your own, these waves, this can really help to better control your insertion.
Okay, let me ask you all the three of you a question combining Professor Hagr local anesthesia proposal with Piotr intraoperative monitoring. If you do a procedure under local and do monitoring, will you be able to relate patient's hearing sensation, what he feels or she feels, with the images you see in your ECOG?
Probably yes, but it's like, I remember not in our hospital, in one other Polish hospital, when the surgeon did stapedotomy, asked, okay, can you hear better, and then patient, oh, maybe a little bit better, but in theory yes, but I'm not a fan of local anesthesia in ECI. Okay, I could do it in Ponto or Baja, in Ponto, at Baja no. Okay, but very rare also. But there is the issue of anesthesiologists. There was the very nice meeting we organized with Medal in New York many years back, and there was the issue that the very people, 95 years old with, the fraction like 30%, and this is the issue in such cases. I understand the issue of local, so then we want to give them chance, because really it is a risk of anesthesia. But in regular case, no. In partial deafness, honestly, I would not go for local. But in theory, yes. But you can imagine. Okay, I put the electrode, and the patient, when they start to move, to talk, if there is movement of the, the temporomandibular joint, so it also could influence you in the keeping. So then there is migration. The patient, oh no, I lost. We put deeper, and then there is. It could be funny, really. But no,
Rahman, Piotr doesn't like local anesthesia. You don't like intraoperative monitoring, or you like?
Well, actually, I like it. Tell you something, like when we start local anesthesia, we were wondering if we're supposed to use the patient F monitor or not, because the patient is awake and we could ask him to move his face, okay? So the same thing when we do a cochlear implant under local, we noticed the first few cases, they were complaining of tinnitus. So I think with the beginner kind of practice, we were not to be as good as now. So we think maybe the tinnitus is one of the monitor for the patient when we do cochlear implants, and we could ask them if the tinnitus is getting higher, we could go slower. So that would be patient himself monitoring the cochlear implants insertion rather than the ECOG. So that would be another replacement for the intraoperative monitoring.
Okay, some more comments. We are reaching the end of our time. You want to say something? We don't have more comments from the more questions. So I would like to thank the three of you for giving such a group of interesting cases, rare cases, I must recognize, and very, very good from a theoretical standpoint, because they challenge what we do every day, and they propose new ways to approach the situation. Thank you for being so good with the time. And after an hour and a half dealing with uncommon situations, some ideas come clear to my mind. Number one is that maybe we don't have to wait as much time as we do now to activate the sound processor in cochlear implants. This is one of the routines we learn when we start doing cochlear implants. You wait for weeks until you turn on the sound processor. But there are a lot of things in medicine that we only do because this is the way we've been doing always. And this is not a very scientific approach. Maybe nowadays, with the improvements in surgical technique, with improvements in technology of the implants, we can reduce, or maybe Professor Hagr, even eliminate the waiting time between surgery and activation. Well, let's see how this change of paradigm evolves in the near future. Number two is that images are crucial in the field of cochlear implants. They help a lot. Maybe robots and navigation system are not as useful as image, but image is crucial. And probably genetics are also crucial in the future. And we must be able to perform routine, good imaging for all our cases. Is the only way to have good diagnosis and improve the results of our surgery. And finally, we are living the era of intraoperative monitoring, not only in otology, but also in other areas of the specialty, head and neck, and in other disciplines, in general surgery. Now, intraoperative monitoring is standard of care. And I'm sure that intraoperative cochlear monitoring in the future will suffer a very important development, and we'll probably see it more and more often in our ORs. We just need to have the right technology easily available for all of us. And before closing, and thanking you for being there for 1.5 hours, I just want to remind you a few practical things concerning our roundtables. First of all, remember the hearing group. You can find us at www.hearing.com. There, it's not just us, but we have the hearing preservation calculator, this tool here. These are 3 tools I would like to show you. This is the tool we use in the hearing group, proposed by the hearing group, published by the hearing group. It's a system to make a hearing preservation calculation give hearing preservation in figures, in numbers, and this is very useful. You can find it for free in the web page I just mentioned. We have also the electroacoustic simulation fitting tool, which is a tool used for more than 900 users right now in more than 25 countries covering all continents. And you have the hearing preservation counseling platform also, which is very, very useful. The hearing preservation counseling platform is a way to approach how we counsel our patients. And if we continue with our program, you can also find, please go to the next slide. We can also find in the hearing boost.hearing.com, you can find certified courses. Here, you have all the courses organized by the hearing group. You will find here a course of hearing implants in Spanish organized by Professor Mario Cernotti from Argentina and myself, which is directed to all Latin American countries and Spain and other courses. And you also have our hearing.com webpage with quality standards, truthful experts, profiles, and publications. And please, next slide. It's important for you, especially for the young people here in the audience, to remember that you can get accreditation by the CPD Standards Office. To get this accreditation of this roundtable, you just have to request by writing us at an email at boost@hearing.com. Be patient because it may take up to 6 weeks to get the accreditation, but the first 30 asking for the accreditation will get this accreditation for free. And finally, next slide, please. Any inquiries, any questions, any comments you have, please go to our webpage. We will be more than happy, all members of the hearing group will be more than happy to answer your questions, to try to solve your problems, to talk with you, to deal with your difficult cases, whatever you want. We are a large group with a lot of experience in the field of cochlear, middle ear, ABI, and bone conduction implants, and we can answer all your and try to help you anytime you want. And remember, there's a group of roundtables. We are on the second, the summer one. We had the first in March 24, and we'll have 2 more roundtables of the hearing group on September 29 and December 15, exactly at the same time as today, from 3 p.m. in Central European time to 4:30 p.m., which is the time what we are right now. Just remind you to keep in touch with us if you need, and thank you for being there. We have had more than 130 attendants all over the duration of the roundtable, and my last thanks to the panelists that have been so good in these presentations. Thank you very much all, and see you in September.